welcome to Introduction to Cardiovascular Anatomy and Physiology and Conduction. My name is Sarah. This is the very first video in our Cardio Learning Solutions YouTube series, so I'm very excited to be sharing this with you guys. This is the very first, therefore it has room for improvement, but let's get into the Introduction to Cardiovascular A&P and Conduction. We've all seen this. This is a coronal view of the heart. We have two atria, the right and left atria. We have two ventricle, the right and left ventricle. And then we have a different set of valves in each structure, as well as structures that carry blood to and from the heart. Each of the atria are composed of pectinate tissue. The right atria specifically has some specialized conductivity tissue we'll get into later, and the ventricles have its very rugged trabeculae. With my experience in the cardiac cath lab, there is a very distinct procedural component to each of these structures, the left and the right heart. And so when we most distinctly refer to the right heart, we're talking about the venous side. And when we discuss the left heart, we're more oftentimes talking about the arterial side. So our heart is a dynamic muscular organ. It will respond to ischemia or lack of blood flow. It has many vessels that work in a coordinated, very beautiful dynamic way. And so if we look at this top picture, we see the top aortic arch, and there are three vessels coming off of that: the brachiocephalic, the left common carotid, and the left subclavian. The brachiocephalic is also termed the innominate artery, and it is an artery of the mediastinum that supplies blood to the right arm, the head, and neck, and it is the first branch off of the aortic arch. This brachiocephalic vessel also supplies the right common carotid. The left common carotid really speaks for itself, and then you have the left subclavian artery. Looking at the cardiac layers of the heart, we see three distinct layers that we talk about most often. Working from the inside out, we have the endocardium, that is the innermost lining of the heart that interacts with the blood as it is pumped through it. Then the thick muscular portion called the myocardium. Surrounding the myocardium, we have the pericardial cavity that is within the parietal and the visceral pericardium. This is usually full of 50 milliliters of fluid, give or take, and it provides lubrication for each contraction of the heart. Then we have the outer fibrous layer that prevents rapid expansion and keeps this dynamic system working properly with each contraction. Taking this coronal view again of the heart, let's look at the cardiac circulatory flow more in depth. Our cardiac circulatory flow begins in the right atria as the blood returning is supplied from the SVC, IVC, and the coronary sinus, which we'll all look at more in depth. But it is pumped from the right atrium through the tricuspid valve into the right ventricle, through the pulmonary valve into the left and right pulmonary arteries. This is where it goes to the lungs, and it is supplied with the oxygen that the blood needs in order to supply the rest of our body with oxygenated blood. From the lungs, it returns to the coronaries are supplied from the aortic valve through the sinus valsalva. Looking at the aortic valve itself, if we were to cut the aorta open, we see that this is a 3-leaflet valve, and within the cusp where those meet is called the sinus valsalva. Within the right and left portion of that sinus valsalva are our coronary ostiums. Speaking of the coronaries, we need to look at our coronary anatomy in an atrioventricular and interventricular plane. The heart is a 3-dimensional, very dynamic organ, and the coronaries supply blood flow to the cardiac tissue, as we discussed, off of the aortic root from the sinus valsalva. coming off the aortic cusp. These are the left and right coronaries. And when discussing the vessels, the left system is often organized into the left main, left anterior descending, and circumflex. However, there's different anatomical versions that can exist within everybody. We're all different. And we can even have a third vessel coming off the left in a true trifurcating fashion from the left main that is often referred to as the ramus, that famous ramus. In the cardiac catheterization lab, we utilize different catheters to cannulate or engage the ostium of these vessels. We will discuss more in length how the heart is a system of pressures and gradients. And so as we engage that catheter in the ostium of the vessel, the coronary ostium, we will see different arterial waveforms that vary in amplitude and type and depend on the interaction with the ostium and the catheter and the aortic root. Speaking more in depth about the main coronary arteries, in that interventricular and atrioventricular plane, the right coronary artery originates in the right sinus of Valsalva and runs in the right ventricular side of the atrioventricular groove. It runs all the way around the heart when you see these two planes come together at what we call the crux. And this is where the posterior descending artery and the atrioventricular node artery originate. The left main coronary artery originates in the left sinus of Valsalva, and its length can vary between 5 and 10 millimeters, and occasionally we're going to see the left main, or that widowmaker, be absent. Although they typically run from the left main, we can have a separation in the ostium and have a dual ostium system where the LAD and the circumflex have their own ostiums. That system of pressures and gradients is a system that can be applied to the whole cardiac structure and function within the body. So if you notice, we have systole and diastole. Systole is the contraction of the heart, and we'll go more in depth about the AV valves and semilunar valves and how they function with S1 and S2. But our systole and diastole are the pumping and filling portion of the heart. And it's very important to note that the coronaries fill with oxygenated blood to supply the myocardium during diastole. So full relaxation of the heart, we see the ventricles are filling with blood, and oxygen-rich blood is filling down the coronaries to supply the myocardium. Certain factors will also affect this pressure and gradient system. This can include valve stenosis or regurgitation, so we have an abnormal function to our valves. We can have structure or heart dilation. We can have hypo or hypertrophy. This is the function and health of the muscle tissue. Our volemic states, are we dehydrated? Are we fluid overloaded? Will affect the pressure and gradient system as well. And our vascular resistance as a whole is going to determine how our pressure and gradient system functions. So in looking at what that gradient means, what does that mean? That is the driving force of flow through the heart with each contraction or each relaxation. With this system being a very delicate system of pressures and gradients, we see this reflected in our waveform monitoring, not only in the cardiac catheterization lab, but also in our critical care units. So if you take a normal aortic pressure, which is shown by the red line in this diagram, and the blue line, which is our ventricular pressure, we have a normal systolic or ejection pressure. The pressure on each side of the aortic valve as it is pushed open during the contraction normalizes because there is a normal, steady, healthy tissue that you just push right through that valve and you get the same systolic ejection pressure. We'll go a little more in depth on this, but what I want you to notice, especially in understanding the effects within the dynamic system and how they affect the gradients and pressures. We'll look at this next slide here of pressures and gradients, and we have an LV pressure and an AO or arterial pressure. And so we see that the LV pressure is higher than the systolic AO pressure. This isn't normal. Your LV pressure and your aortic pressure during systole should match, should be very, very close. And because we have aortic stenosis or hardening of the aortic valve, the LV pressure has to be increased in order to open that stenotic valve and push into the aortic to provide blood flow to the rest of the body. So this is a concept if you are starting to learn about hemodynamics, and hemodynamics specifically in the cath lab or at the bedside in your critical care unit. Remember that we have pressures and gradients. And when you have different gradients or changes in those pressures, there is a factor that is causing that. For instance, it takes more pressure from the LV to contract and push through the stenotic aortic valve. And so we see this here mimicked in our pressure. This is just a very, very rudimentary intro to this concept, but it's something that will carry later into other courses as well. So for this patient specifically with aortic stenosis, we can treat this, and this is by replacing the aortic valve. And this is done during a procedure called either TAVR or during actual open heart. These are images we see in the cardiac catheterization lab, and they are created by fluoroscopy or X-ray and the injection of contrast. By injecting contrast through the catheter upon engaging the ostium of the coronary, and of course monitoring our waveforms, we can visualize abnormalities and provide treatment through the use of angioplasty and stenting, or we can escalate to surgery consults, including the use of coronary artery bypass grafts. Again, one thing to remember is how we work in the atrioventricular and interventricular planes. These views, our angiography anatomy of our coronaries, are taken in multiple views because we are not working in a single plane. Our hearts, again, are three-dimensional machines that in a single view may change the course of treatment drastically. In diving further into our coronary anatomy and understanding of the structures that supply the myocardium with oxygen-rich blood, we need to look at our coronary segmenting. Looking at this segmenting, we need to break it up into the right and left system, with the start of the vessel being that is which called the ostium. The RCA, or the right coronary artery, feeds the SA node, the AV node, and it is located predominantly around the right atria and around the inferior side of the heart, with 80% of people having the PDA, or the posterior descending artery, coming off of the right, and this determines dominance. People can be right, left, or co-dominant, but predominantly people are right. So we have our left main starting off our left system, which is also called the widowmaker, and from the left system we have the circumflex. The circumflex gives rise to the obtuse marginals. Then we have the LAD. The LAD comes down the apex of the heart, which supplies the main septal region and the left ventricle. The LAD gives rise to our septals and our diags. An easy way that I remember this is from the left, the LAD, the septals, and the diags. The septals run towards the RCA, RS, and the diags run towards the circumflex, CD. So in looking at this overview of coronary segmenting, this is especially important in the cardiac cath lab as we angioplasty and deploy drug-eluting ischemia is coming from can also give us a clue to what to expect during the case. For example, if we have a patient that comes in with ST segment elevated myocardial infarction and they have ischemia showing in their 12-lead EKG that presents from the right coronary artery, I'm going to be most concerned about bradycardia. With the left system, if a patient presents with ischemia from the left side of the heart, I know that that left anterior descending artery wraps around the apex of the heart, which wraps around the ventricle. I'm going to be most worried about pump function, because when our myocardial tissue dies, it doesn't regenerate. It's dead, it's dead. That's why time is muscle in the cardiac cath lab. that wraps up our very first course. Again, thank you guys for watching. And if you want more, comment down below, subscribe to stay in tune with everything that's going on, and I will see you guys in the next one.